Hurdle step screen. Objective: to examine simultaneous mobility of one limb and stability of the contralateral limb while maintaining both hip and torso stabilization during a balance challenge of standing on one leg. Equipment: 2 uprights to anchor string, chair or table, legs, 36-inch or 0.9 meter piece of string, 48-inch or 1.2 meter wooden or plastic dowel. Instructions: briefly discuss the protocol so the client understands what is required. Fasten a piece of string spanning 2 points at a height even with the underside of the foot positioned parallel with the floor when it is raised to a height that flexes the hip to 70 degrees, approximately just above halfway up the tibia. Have the client stand with both feet together and the front edge of toes aligned directly beneath the string. Ultimately, this test should be performed with the feet positioned at gait width apart, i.e. 2.8 to 3.5 inches or 7 to 9 centimeters, to simulate single leg support during walking. Place the dowel across the client's shoulders, holding it parallel to the floor, similar to the placement of the bar during the traditional barbell squat. Instruct the client to load onto one leg and slowly lift the opposite leg over the string, flexing the hip to clear the string, and then gently touching the heel of the raised leg to the floor in front of the string before returning to the starting position. The foot only needs to clear the string and does not need to be lifted as high as possible. It is important to remember not to cue the client to use good technique, instead observing the natural movement. Repetitions need to be performed slowly and with control. Have the client repeat the movement with the opposite leg, completing a series of repetitions with each leg so that the trainer can make the necessary evaluations. Allow sufficient practice trials to accommodate learning before administering the test screens. Observations. Frontal view. First repetition. Observe the stability of the foot, i.e. evidence of pronation, supination, eversion, or inversion. Second repetition. Observe the alignment of the stance leg knee over the foot, i.e. evidence of knee movement in any plane. Third repetition. Watch for excessive hip adduction greater than 2 inches, 5.1 centimeters, as measured by excessive stance leg adduction or downward hip tilting toward the opposite side. Fourth repetition. Observe the stability of the torso, i.e. evidence of torso movement in any plane as demonstrated by movement of the dowel. Fifth repetition. Observe the alignment of the moving leg, i.e. lack of dorsiflexion at the ankle, deviation from the sagittal plane at the knee or ankle, or hiking of the moving hip. Sagittal view. First repetition. Observe the stability of the torso and stance leg. Second repetition. Observe the mobility of the hip, i.e. allowing 70 degrees of hip flexion without compensation or anterior tilting. General interpretations. Identify the origins of movement limitation or compensation. Evaluate the impact on the entire kinetic chain. Table 7-10, hurdle step screen. In the anterior view of the hurdle step screen, when you are looking at the joint reference or joint location of the feet, the compensation you may see is a lack of foot stability. The ankle would collapse inward and the feet would turn outward. Key suspected compensations of overactive or tight muscles would be the soleus, lateral gastrocnemius, and the peroneals. Key suspected compensations of underactive or lengthened muscles would be the medial gastrocnemius, the gracilis, sartorius, tibialis group, gluteus medius and maximus, and the inability to control internal rotation. In the anterior view of the hurdle step screen, while looking at the joint location or joint reference of the knees, you may see the knees move inward. The key suspected compensation of overactive or tight muscles would be hip adductors and the tensor fascia latae. The key suspected compensations of the underactive or lengthened muscles would be gluteus medius and maximus. In the anterior view of the hurdle step screen, the joint reference or joint location of the hips, you may observe hip adduction, greater than 2 inches. The key suspected compensations of overactive or tight muscles in this compensation would be hip adductors and the tensor fasciae latae, and the key suspected underactive or lengthened muscles are the gluteus medius and maximus. At the hips, if you see the stance leg hip rotation, where the hip rotates inwardly, the stance leg or raised leg may have tight internal rotators, and the stance leg or raised leg may have lengthened or underactive external rotators. In the anterior view of the hurdle step screen, while viewing the torso as a joint location or joint reference, you may see a lateral tilt, a forward lean, or a rotation. For overactive or tight muscles and underactive or lengthened muscles, the key suspected compensation is the lack of core stability. In the anterior view of the hurdle step screen, while viewing the raised leg, you may notice 3 compensations. The first is a lack of ankle or dorsiflexion. The key suspected overactive or tight muscles would be the ankle plantar flexors. The key suspected underactive or lengthened muscles would be the ankle dorsiflexors. The second compensation of the raised leg in the anterior view of the hurdle step screen may be that the limb deviates from the sagittal plane. The key suspected overactive or tight muscles are that the raised leg hip extensors are tight and the raised leg hip flexors are lengthened or underactive. The third compensation of the raised leg that you may see in the anterior view of the hurdle step screen is that the raised hip is hiking. The overactive or tight muscles may be the stance leg hip flexors, which would limit the posterior hip rotation during the raise, and there are no listed underactive or lengthened muscles, aside from the previously mentioned ankle dorsiflexors and raised leg hip flexors. In the sagittal view of the hurdle step screen, focusing on the joint location or joint reference of the pelvis and the low back, you may see an anterior tilt with a forward torso lean. Suspected compensations of overactive or tight muscles would be the stance leg hip flexors, and underactive or lengthened would be the rectus abdominis and hip extensors. A posterior tilt with a hunched over torso would indicate tight rectus abdominis and hip extensors and lengthened or underactive stance leg hip flexors. Shoulder push stabilization screen. Objective: to examine stabilization of the scapulothoracic joint and core control during closed kinetic chain pushing movements. Instructions: briefly discuss the protocol so the client understands what is required. The client presses his or her body off the ground as the trainer evaluates the ability to stabilize the scapula against the thorax or rib cage during a pushing type movement. Instruct the client to lie prone on the floor with arms abducted in the push-up position or bent knee push-up position. Ask the client to perform several push-ups to full arm extension. Subject should perform full push-ups, modify to bent knee push-ups if necessary. It is important to remember not to cue the client to use good technique, but instead observe his or her natural movement. Repetitions need to be performed slowly and with control. Observations: observe any notable changes in the position of the scapulae relative to the ribcage at both end ranges of motion, i.e. the appearance of scapular winging. Observe for lumbar hyperextension in the press position. General interpretations: identify the origins of movement limitation or compensation. Evaluate the impact on the entire kinetic chain. Shoulder push stabilization screen. In the sagittal view of the shoulder push stabilization screen, at the scapulothoracic joint location, a compensation that you may see is that there is an exhibition of winging during the push-up movement. The key suspected compensations are inability of the parascapular muscles, i.e. the serratus anterior, trapezius, levator scapulae, and the rhomboids, to stabilize the scapula against the ribcage. That can also be due to a flat thoracic spine. In the sagittal view of the shoulder push stabilization screen, while viewing the trunk, you may see hyperextension or collapsing of the low back. The key suspected compensation is a lack of core abdominal and low back strength resulting in instability. Thoracic spine mobility screen. Objective: to examine bilateral mobility of the thoracic spine. Lumbar spine rotation is considered insignificant as it only offers approximately 15 degrees of rotation. Equipment needed is a chair, a squeezable ball or block, and a 48-inch or 1.2 meter dowel. Instructions: briefly discuss the protocol so the client understands what is required. Instruct the client to sit upright toward the front edge of the seat with the feet together and firmly placed on the floor. The client's back should not touch the backrest. Place a squeezable ball or block between the knees and a dowel across the front of the shoulders, instructing the client to hold the bar in the hands, i.e. front barbell squat grip. While maintaining an upright and straight posture, the client squeezes the block to immobilize the hips and gently rotates left and right to an end range of motion without any bouncing. It is important to remember not to cue the client to use good technique, but instead observe his or her natural movement. Ask the client to perform a few repetitions in each direction slowly and with control. Observation: observe any bilateral discrepancies between the rotations in each direction. General interpretations: identify the origins of movement limitation or compensation. As an individual rotates, the facet joints of each vertebrae experience shearing forces against each other. One way to reduce this force and promote greater movement is to laterally flex the trunk during the movement or at the end range of movement. This screen evaluates trunk rotation in the transverse plane. Therefore, any lateral flexion of the trunk, the dowel tilting up or down, must be avoided. Evaluate the impact on the entire kinetic chain. Remember that the lumbar spine generally exhibits limited rotation of approximately 15 degrees, with the balance of trunk rotation occurring through the thoracic spine. If thoracic spine mobility is limited, the body strives to gain movement in alternate planes within the lumbar spine, e.g. increase in lordosis to promote greater rotation. Table 7-12, Thoracic Spine Mobility Screen. On the transverse plane of the thoracic spine mobility screen, while viewing the trunk, there may be no compensation as long as the trunk rotation achieves 45 degrees in each direction. In the transverse view of the thoracic spine mobility screen, while viewing the trunk, bilateral discrepancy, assuming no existing congenital issues in the spine, may occur. The possible biomechanical problems may be side dominance, differences in paraspinal development, torso rotation, perhaps associated with some hip rotation. Note that the lack of thoracic mobility will negatively impact the glenohumeral mobility.